Hello and welcome to this replay of a special presentation in celebration of Brain Awareness Week, an annual global campaign by the Dana Foundation to support brain science. For more information, go to brainawareness.org. We at the Depression and Bipolar Support Alliance of Colorado Springs were honored to host this event for the public, and we look forward to hosting more of these events in the future. You can stay updated on future events by visiting our website, dbsacoloradosprings.org, or by finding us on a variety of social media platforms. Tonight's topic, Stress and Mood Disorders, Finding the Balance, is presented by Dr. Imad Melhem, Chief Medical Officer at Diversus Health Colorado Springs, a member of the executive leadership team, leading the psychiatric service line with oversight of clinical operations, service and program development, quality and compliance, as well as organizational health. Born and raised in Beirut, Lebanon, he completed his psychiatric residency training at the University of New Mexico, followed by a fellowship in child and adolescent psychiatry at Harvard's Massachusetts General and McLean Hospitals. He carries a Master of Medical Management degree from Carnegie Mellon University and achieved the Certified Physician Executive credential through the American Association for Physician Leadership. Dr. Melhem serves on both the NAMI Colorado Springs and DBSA Colorado Springs Board of Directors. Let's turn things over to Dr. Melhem. Enjoy.
It's a great pleasure to be here amongst you today to present on this very important subject, that is stress and mood disorders and finding the balance. It's also a great pleasure to be asked by DBSA Colorado Springs and the Dana Alliance to speak on this important occasion that is the Brain Awareness Week. I will start initially by running through some information that summarizes mood disorders, stress, and I hope by the end of this to leave the audience with some ideas about what do we know about mood disorders in general terms. I'm not going to be too technical, but I hope it's relevant information to portray or kind of expose the interplay between the effect of stress on mood disorders and what are some of the ways to battle and kind of find that balance, as the title suggests. Like Jeff mentioned, I was born and raised in a country that suffered through years of war, and we will get to war as one of the stressors in leading to precipitating mood disorders or leading to problems that the brain that would affect the brain in general, as one example of stress. Like Jeff mentioned, I really have been here for about a year and a half or a little bit more after joining Diversus Health, which is a local community mental health center covering the El Paso, Teller, and Park counties, where we provide care to mental health care to patients from these three counties. It's been great to be here, and I would go into the presentation right now, and then afterwards, hopefully we can have some Q&A, and I'll be happy to answer any questions. To start with, mood disorders in general are typically classified into two main big umbrella groups. One of them is bipolar disorders, and the other one is depressive disorders. Again, without going into the technicalities of what each one of them is, I would just like to point out that these disorders nowadays are seen as a spectrum of mental health problems that start at different stages of life and that can go on for a period of time. If not most of the time, they are chronic in nature. I will start first by talking about bipolar disorders, which is, as you see on the screen, it is classified into at least 7 different categories. And these are groups that try to create a language that everybody can understand when it comes to the nature of the disorder and the criteria that allow us to diagnose the person presenting with mood symptoms, with bipolar, depression, or other. There are many different kinds. You can go between type 1 bipolar 2 cyclothymia, and the other categories you can see on the screen. But really what bipolar disorder is a affective disorder or a mood disorder that is characterized by switches in mood and energy that can go between developing a depressive episode, which we will talk in a little bit about, or what we call mania or hypomanic episodes, which is, to put it simply, could be seen as the opposite of depressive episodes. And when we talk about those episodes, really these are symptoms that affect almost every function of the brain and can lead to a lot of impairment. That definitely mania or hypomania are the main distinguishing factor between what we call depression, major depressive disorder, or bipolar disorder. And that has specific relevance especially in how can we design treatment and what we can recommend for the person presenting with this problem. Statistically speaking, bipolar disorders globally affect around 45 million cases. Of course, all these numbers that I'll be sharing can vary from one source to another. But if we think about the United States among adults, in the past year, the prevalence of bipolar disorder is rated around 2.8%, but that is typically ranges depending on how you define it. If you define it very tightly, it could be anywhere between 0.5 and 1.5%. It is present similarly amongst males or females. And if you take that next statistic, about 4.4% of the adults in the United States experience bipolar disorder at some point in their lives. Now, the key thing is that half to 2/3 of those cases start in childhood or adolescence. And 60% of people presenting to get care, they present with a depressive episode first. And that frequently can get misdiagnosed as major depressive disorder, when in reality, there may be that other aspect that we refer to as mania or hypomania, which is an elevation in mood and energy with increased energy, lack of sleep, increased impairment in judgment or impulsivity, so on and so forth. In adolescence, the prevalence among adolescents aged 13 to 18 is also around 2.9%. And it's, however, a little bit higher for females compared to males. As compared to depressive disorder, and again, like I mentioned, bipolar, the term bi is bipolar because it has two poles. One of them is depression, and that is where that confusion can sometimes come in from a diagnostic perspective. Depressive disorder can also be classified into at least eight categories according to the DSM or the Diagnostic and Statistical Manual for psychiatric disorders, ranging from disruptive mood dysregulation disorder, which is more of a severe mood disorder presentation that starts in kids or adolescents, major depression, persistent depressive disorder, what used to be called dysthymia, premenstrual dysphoric disorder, and so on and so forth. And all of these distinctions also, again, exemplify the idea that there is a spectrum of disorder. It's not one thing, and it can present in different severities where the person presents with certain symptoms, but not others, and for a different amount of time. If we think about the statistics and depression or depressive disorders in adults are some of the most common mental health disorders in the United States, but also globally. It's also one of the problems or mental health conditions that carries a lot of impairment, and it's considered to be, between quotes, a burden on the person's life, their family, the economy, etc., due to the limitations that it causes because of those impairments. When someone is feeling low in mood, lacking energy, unable to sleep appropriately, developing guilt feelings of worthlessness, suicidality, among other symptoms, it affects every aspect of the person's life, and it impairs the ability to carry out major life activities or even sometimes minor life activities. Again, in adults in the United States, that prevalence can be around 21 million adults only in the United States, which is around 8.4 of the population have had at least one depressive episode in the last year. Excuse me. It is higher among women compared to men. And it is highest among ages 18 to 25. It's about 70% of those patients with depression. And one interesting distinction is that it is also highest among people who report having multiple 2 or more races. In adolescence, again, this is another one of those disorders that can start early in early age. And it's about 4.1 million adolescents between ages 12 and 17, and only in the United States, have had at least one depressive episode that meets the criteria for major depression. Similarly, it's higher among females compared to males. And again, it's also highest among adolescents who report 2 or more races. Before we go into the stress, I would think the emphasis about mood disorders, or otherwise we talk about them as affective disorders. These are disorders that are, again, very disabling, but also some of them can run in families. They are, and especially in bipolar disorders, it's highly genetic as a disorder. It runs in families, and nowadays, more and more, when we're interviewing a patient, we ask the questions about family mental health conditions and problems. And frequently, the answer would be that people were not necessarily diagnosed with the problem, but the family knew that there was an issue one way or another, but that wasn't diagnosed. But they are pretty prevalent in the community. And if anything, with the pandemic, these mental health conditions in general, anxiety included, but also mood disorders have been increasing in rates and prevalence, and creating a lot of dysfunction in people's lives and a lot of pressure on healthcare systems as well to meet the needs and the treatment needs of the patients presenting. I'll shift a little bit to the idea about stress and what defines stress. Stress, I tried to split it into 3 different categories based on how we think in psychiatric, in the psychiatric formulation, which is based on the biological, the psychological, and the social pieces. From stress can be multifactorial, can vary in how long it can present and at what time it can present in people's life. But if anything, most of us will go through stressful periods of our life that could be social in nature. I listed some examples such as stigma, discrimination, unemployment, homelessness, poverty, problems in relationships, the inability to access care. All of these can be precipitating factors or stressful factors that can prevent the patient or the person from reaching or accessing care, or that can precipitate mood disorders. Stress is seen as one of the major precipitating factors of triggering mood episodes in general. When we think about physical or biological stress, one may think about medical problems, definitely substance use, which is highly comorbid with mood disorder. When I say comorbid, means it's one of those conditions that can be the result of a mood disorder or can cause over time the precipitation of a mood disorder. But in general, up to 50% of patients, especially with bipolar disorder, can have a substance use of some kind coming together, which only can cause more problems. Other biological things could be sleep habits, dietary habits, among other things. But also, when we think about major public health events, such as a pandemic or COVID, more and more, there's a lot of research that is suggesting that COVID not just can cause or precipitate mood problems because it causes isolation, but there may be also biological ways that COVID and other medical issues can really precipitate or even come together with depression or other problems. When you think about bipolar disorder, it tends to be more genetic, but also can be subject to the effect of stress. Of course, not to mention psychological factors that can be stressful to us would be abuse, trauma, loss, neglect, violence, among other stressful events. So when we think about it from that perspective, you can probably think that any one of us who are attending this presentation today have had at least one of those issues at some point in their lives, or they will have, whether, I hope not, but we may be subject to certain of those stressful events. And while we sometimes cannot prevent stress, but there is one thing we know for sure is that stress and mood disorders play into one another. If you have bipolar disorder, that may cause you a lot of impairment that can lead to worsening of functioning, that can lead to unemployment, which can cause, again, poverty. There are a lot of outcomes that can lead the problem and the mental health problem to even get worse. I will introduce a concept and then I will hopefully link all of the above together. The concept of neuroplasticity. When we think about the brain in general, given that this is Brain Awareness Week, I thought to include a little bit in my presentation, a little bit about neuroplasticity, given that some or a lot of the recent research will talk about that as being one way to think about mood disorders or mental health conditions in general. By definition, neuroplasticity is the ability of our nervous system to respond and adapt to the environmental challenges. Environmental challenges are definitely, could be everything I just talked about that we refer to as stress or trauma or environmental or medical issues. Neuroplasticity also is basically a functional and structural mechanism that can help the nerve system, the nerve cells or neurons, to connect with one another in order to adapt to what could be going on in our lives. And also the formation, not just of new connections, but the creation or the birth of new neurons, which is an idea back in the day. We used to think that once you lose some of your brain cells, the brain was not definitely always capable of replenishing that. What we know now from a developmental perspective is that just like any organ in the body of the human, the brain also goes through maturational phases that are driven by neuroplasticity. That concept, I just wanted to remember it as we talk about stress. Again, like I mentioned, mental health conditions can be worsened by a wide spectrum of variables and factors. According to the APA or the American Psychiatric Association, stigma, for example, comes across as one of the main factors that can worsen mental health conditions and that can contribute to preventing people from getting treatment, being afraid of being labeled, and so on and so forth. When we think about stress, the way I defined it earlier, it is also considered as the major or the most important element, environmental element, that of the susceptibility to develop mood disorders. And that especially is correct in depression or major depressive disorder. The exact correlation or relationship between stress and the formation of disease or disorder is not totally yet understood. But again, that concept of neuroplasticity can help us understand it a little bit better. The way we think about mood disorders from that perspective could be characterized by a deficit in that neuroplasticity, meaning it's a deficit in the ability of the brain to cope and adjust and form new connections in order to manage and cope with the stressors that we have. That can happen, obviously stress can happen at many different stages. When you think about trauma and abuse that can happen at an early age, during that time, the brain is developing and maturing, meaning the nerve cells or the neurons are creating connections, you are learning new things, and disruptions at that time in neuroplasticity can lead to later psychopathological problems, meaning can lead to mental health disorders, especially depression or major depressive disorder or that spectrum. I'll also throw in a little bit about how does that happen by just focusing on one of what we call one of the substances in the brain that seems to be involved in that maturational, normal process of development of the brain, but it's also seen to be involved as a marker in the blood of what could be mitigating, if you want, or modulating these effects, the effect of stress and the effect of treatment even. This substance is a neurotrophin, which is called the brain-derived neurotrophic factor. Neurotrophic means it's a substance that's supposed to be helping the brain cells to thrive and survive. It is also involved in that maturation process, the development process, like I mentioned. And that has been seen, according to recent research in the past decade or more, as one of the main substances involved in the effects of stress on the functions of the brain and the development of those symptoms. One other interesting finding as well is that treatment of depression, for example, can actually normalize the levels of that substance and can help manage over time if somebody is on an antidepressant, for example, or getting treatment for major depressive disorders over a period of time. In our language, we call it maintenance treatment. Over time, it may help also normalize that deficit in neuroplasticity that I mentioned before. So again, if you think about stress can cause problems in neuroplasticity, deficits in neuroplasticity can show themselves as depression or other mental health conditions, and treatment of those conditions, especially depression, can improve that neuroplasticity. So it's a full circle, and it does it through, again, modulating those deficits or the factors that were not functioning well from the depression. I will not elaborate too much about that, but I think, to me, if we connect all of the above, again, stress is something that's going to happen, and unfortunately, we live in times where we've had enough of our share in the last at least 2 years. But when you think about our patients, especially in community mental health centers or in psychiatric offices, but also in primary care physicians' offices, the effect of stress on patients who already have a diagnosed mood disorder, whether it's a depressive disorder or bipolar disorder, is not to be undermined. It is something to keep in mind. It can come in many different ways, and it affects different people differently, especially if it starts early on in childhood or adolescence. It can have a lasting effect, especially if it lasts for a long period of time. This is where what I mentioned before, living in a country that has a war, for example, or sustaining abuse or neglect, again, for periods of time, those events or stressful events may challenge the ability of the brain to cope with, as it's supposed to cope with the stress, because it's lasting too much. It's basically having the brain having multiple hits that at some point can lead to changes in the neurotrophic factors, among other things. We think of serotonin, norepinephrine, and other hormones or neurotransmitters in the brain. And that can lead to the presentation that we see in our offices or in the hospitals, where we treat what we call depressive episodes, but also other mood episodes. How do we find the balance? And finding a balance is not an easy thing because of the previous, especially in that social column that I described, that when you have a mental health issue, especially in our healthcare system, that sometimes can be disjointed or really doesn't always offer the opportunity for the patient to have easy access to care, let alone the other factors such as stigma. Like we mentioned, it can be a barrier for people thinking about getting care because they're embarrassed or they feel they're going to be labeled. If you are a member of a minority group, whether racial or other, the fear of discrimination or the fear that the provider may not understand your condition. If you are in poverty or suffering from transportation issues, we see that all the time at Diversus Health, where patients can't access us by transportation, they live far away. All of these factors can lead to worsening of that mental health condition and challenge the ability of the brain to develop coping mechanisms the way we defined it from a biological perspective. And unfortunately, when you see patients with mental health problems, and in this case, I'll mention schizophrenia among other ones, those mental health problems or conditions tend to come with other problems as well. They may have a higher susceptibility to high cholesterol or high blood pressure, smoking, emphysema, and so on. But especially we talked about substances and substance use disorders. Again, substances can be a biological attack on the brain that can undermine the processes we just mentioned. In order to find the balance, I think many things have to happen, and these are not things that necessarily the patient alone can be responsible for, or especially if you think about it, a patient who is suffering from a depressive episode or having an impaired judgment because of bipolar disorder or any of the categories we explored earlier, they are most of the time at the lowest part of their lives. And expecting them to be able to navigate a very complex healthcare system in our country cannot be a reasonable idea. But I think from that perspective, assuming the patient shows up for care, it's key to always, as a system, whether you're a mental health provider or a family or a relative, to always focus on the main idea of early identification of the problem. One of the statistics we know about is in bipolar disorder, for example, the average delay in diagnosing bipolar disorder is about 10 years, but that from the time the symptoms have started. And those 10 years, given that bipolar disorder usually on average starts around 21 years old or so, or is kind of diagnosed around then, because it may start way earlier, you can easily tell that those 10 years are probably the most important years from a brain development, from exploring life, going to college, having romantic relationships, having a job, etc. So it is important not to risk that period of time, and identifying and correctly diagnosing depression, bipolar disorder in all of their categories is very essential, and intervening as soon as we diagnose. At the level of the patient, definitely raising the awareness and having education, such as the Brain Awareness Week, and having more community events that can take that label and that stigma away from mood disorders. And most importantly, teaching and educating our patients about the chronic nature of these conditions. These are conditions that could go on forever and may need treatment for a long period of time, especially the more severe, the more we talk bipolar, schizophrenia, and other severe mental health condition. But certain types of severe depressive disorders may necessitate treatment forever. Identifying the symptoms, educating about the patterns of behaviors and the symptoms for the patient is highly important. In order to find the balance, I definitely stress creating a support network. Again, this is a multifactorial, meaning this is a problem, a condition that needs multiple interventions in order to maintain, to treat, and to get that mental health issue to recovery or at least remission. Creating a support network through family, through the healthcare provider, friends, among others, is highly necessary in that case, to help the patient when they experience those severe symptoms and they may lose their judgment or even their insight, and they have an impaired function that may make them want to have suicidal thoughts or end up in risky behaviors. Having someone to identify those patterns is highly important. Definitely, we always recommend that the people or the family or the surrounding of a patient with mood disorders also is not to be dismissed, and kind of making sure that that core of people has also the awareness of the effect that such disorders may have, not just on the patient and the suffering of the patient, but also on the surroundings and how it affects them, in order to be able to manage and cope with that condition and help the patient as well. From a treatment perspective, I won't go into too many details. There are a lot of options nowadays for treatment, but definitely whether it's bipolar disorder or depressive disorders, they all could benefit from psychotherapy in its different kinds, whether it's individual, group, family focused, medications. There are a lot of new treatment options nowadays, such as transcranial magnetic stimulation for depressive disorder. Many of you have heard about old school that are that have a bad reputation, even though they are pretty effective treatments, such as ECT or electric shock therapy, and so on and so forth. So there are medications, there are psychotherapy type of modalities, and there are the non-medication routes that I just talked about. There are new evolving trials, and such as ketamine and other experimental or already in use modalities of treatment. That also, not to forget as well, the developing healthy habits or the non-medication aspects, the routines, the healthy sleep cycles, diets, etc., and managing any other problem that can come or co-occur with the mood problem. I listed here maintenance treatment, and I focus a lot on that based on what I mentioned before. In order to see those biological effects on the BDNF, for example, treatment cannot be in an episode and then dismissed afterwards or ignored. It's maintenance treatment, especially in bipolar disorder, is a chronic and long-term treatment that allows the brain to start recovering the functions that were challenged during the episode itself or because of stress and others. Finally, I listed the social responsibility, the professional responsibility, and how can we find or provide our patients with the balance they need through measures that are beyond the office and the clinical office that basically would address those social issues, definitely, where again, there's a lot of research and statistics that show that patients who have two or more races, they are more susceptible to having depressive, as you saw, depressive episodes, for example, having unemployment, hopelessness, inability to actually access care and transportation issues. There is a social responsibility from a political, from a city, state, all levels really, to make sure that our patients, our mental health patients who suffer through debilitating diseases or disorders can have the opportunity to get the treatment that they need, because those treatments, they do work and they can change the course of the problem, of the illness, and can provide the person the ability to function better and regain and catch up on those years that they may have missed because of the mental health problem, whether depression, bipolar, or other. From a professional perspective, this is what all psychiatrists or mental health providers at all levels, we believe that our work and advocacy will never end, and we have to push the envelope over and over again to again create that level field that allows people who are experiencing debilitating symptoms to get the chance to access to treatment. Stigma goes without saying, but again, from that perspective, I think when you think about fair treatment of anyone with any kind of a disorder, a disability, or inability to function at the level that society decided to define functioning. Again, we have to do everything we can to fight the stigma in every way possible, and early on in our schools, in our playgrounds, and in our work environments. There are a lot of studies that can define stress not just as being unemployed, but you can be employed and still be unhappy at your job and actually experience symptoms that can get to the level of a depressive episode, so on and so forth. I think in general, I will end with, on a positive note, we are at an age where neuroscience or brain science has developed enough to allow us to really provide good treatments for mood disorders in general. And with a lot of the efforts that I mentioned and the collaboration between mental health providers, organizations like DBSA and NAMI, involving the patient and their peers, their families in that approach to treatment and raising the awareness about mental health issues is a necessary step that otherwise would leave the patient in a very lonely place, suffering with symptoms that they may or may not understand, and trying to fight a battle that they cannot win on their own. The future is much brighter, I think, from a brain research and more awareness, but we have all to always remember that each one of us can serve in one of those areas to help, again, make mental health a priority in this country. And you can hear, I think, in the latest State of the Union, there is hopefully more awareness and more investment and resources to improve the mental health that's been, in my opinion, an epidemic, especially in kids and adolescents, which is the population I treat. That is definitely a crisis that has been not talked about enough, that has been going on for a long period of time outside of certain environments. It needs to be talked about even more. The awareness needs to be higher, and each one of us can participate in that. I will end on this note. I hope I provided you with a not too technical of a presentation about mood disorders in general, in two of its main categories, depressive disorders and bipolar. We talked about stress and the effects of stress, and I hope that I gave you a few ideas about what is necessary for a patient, but also the environment of that patient to find the balance. I will end here and I'll open the stage for any questions.
We at DBSA Colorado Springs wish to respect the personal privacy of those who attended this presentation. As such, we have edited this portion of the presentation to remove the faces, names, and voices of those who ask questions. You mentioned recovery in the brain and extended exposure to trauma such as war. Is the brain able to recover from these traumas that you mentioned?
Yes, based on that approach that we talked about, where you're seeing the brain as an organ that is alive, that is able to cope with pressure and stress and even with genetic problems, there is definitely a lot of hope that, yes, faced with traumatic experiences, the ability of the brain to create new connections and fix and repair some of the deficits, that definitely is something. Now, that varies between one person to another, and the extent and the severity of the trauma, for example, or how bad it had been. But again, this is the importance of long-term treatment, because that's when you are more likely to see the changes and improvements. And if any reparation is possible, it's going to take some time with doing all the right things, such as avoiding drugs and getting the treatment and taking the medications and so on and so forth.
In your presentation, one thing jumped out at me as not being new, and that was you're saying that it takes 10 years from onset of symptoms to proper diagnosis and then treatment. And that caught me because I've heard that number for 20 years now. In your role as the director of a community mental health organization, what's your take on that?
Yes, I believe I do. Now, typically, the problem with our healthcare system is that when I'm sitting in an office or through a camera and a telehealth, you're only waiting for the patient to show up in your office, which is unfortunately how most of our healthcare system in the United States has been built around treating these acute problems, meaning you hurt yourself, you go to the emergency room. In mental health conditions or in psychiatry in general, focusing on the preventive aspect of care is highly important because you want to be able to detect the problem way before it gets to be becoming severe. And now we're dealing with a suicidal type of behavior or self-injurious behaviors. So the doctors, the providers, the counselors, they're all aware of that, but they are busy professionals. They're sitting in an office and seeing one patient after another. So they basically, that's their job and that's their career. Now it's up to us from an administrative, as a medical director, as an organization, but also through our partnership. The question is always, how can we develop community collaborations, like I mentioned, at schools to raise the awareness in every possible place so that a patient can be, or a person who is struggling, it doesn't have to be depression or bipolar, but if they are struggling, instead of being made fun of or isolated, to identify those good citizens who are aware that this could be something worse than just being stressed out or not sleeping well or something like that, that making sure to raise the flag and say, hey, Johnny is maybe having a hard time and maybe developing almost a lot of the empathy and kind of guiding that so that they can reach us. I wish I can tell you that, we had enough providers to take care of all of El Paso County. That's one of the things we are working on day in and day out to really improve the ability for people to access us. There are people who are interested in getting treatment, and yet when they call us or any other provider in this country in general, they are told you have to wait this amount of time and that amount of time. Figuring out how can we get patients in to get the treatment they need early on, because like I said, by the time people are reaching for treatment, the problem typically has already been severe enough. And we're also trying to catch up against time to stabilize the brain, to function a little bit better. And even finding the right type of a medication or treatment sometimes takes a lot of time. So yes, we're aware, but we're, again, short on every kind of provider, whether it's nursing or mental health counselors or doctors or nurse practitioners and physician assistants. In every domain, we have a workforce shortage.
As someone who was just diagnosed a year ago at the age of 60, I wonder if you can comment on late onset bipolar diagnoses. What age do you consider to be late onset? And in your opinion, are these late onset diagnoses generally accurate? Is there an explanation for how these people can slip through the cracks for decades, many of whom are living apparently successful lives without overt symptoms?
Absolutely. And that goes back to the idea of how two people may have the same diagnosis, but they may present differently depending on their early life experiences, depending on how much resilience they had, and really where you're starting from. So if you had a bipolar disorder, especially when it comes to the less severe forms, that can go under the radar because some of the symptoms are not easily detected. When you think about, so it's not late onset, meaning the problem didn't start then. It had started a long time ago, but the symptoms were either mitigated because you were employed and you had a support network. A lot of times in schizophrenia is a typical mental health condition that unfortunately it's kind of degenerative. It keeps going downhill even when we treat it. And that is a problem that because we don't have yet treatments that can cure or get it into remission like we do in depression and bipolar disorders, for example. But a lot of the symptoms, some people come to us and they're presenting for depression and they may have 10 depressions, but that hypomania that I mentioned early on, which is a smaller mania or a less severe mania, can go sometimes under the radar because people may feel super functional. Suddenly they're working 90 hours a week. They're bubbly, they're, happy, etc. And those are different presentations. So it is not unusual. If you take, in my clinical experience, a lot of people have the symptoms really becoming a problem and causing an impairment in the functioning at work or in life in general after menopause, for example, where that hormonal change. We have patients who present to us with psychotic breaks after delivering a baby. And usually that in 80% of the time, it's bipolar disorder. It's not schizophrenia. They just happened because these factors that include not only brain neurotransmitters, hormonal changes, and environmental or life changes. So in general, it's unlikely that it started at 60 or 65. It has started a long time ago. But again, there may have been enough ability to cope and not as much hits on the brain, if you want, that made it go under the radar. But the symptoms, if you dig deep enough, they have been there, I'm sure, for a while.
I have a 24-year-old grandson who began exhibiting symptoms at age 20. It took 4 years in Colorado Springs for him to get treatment. Would you say he has a better chance of long-term recovery because he's now stable after homelessness in jail and the usual horrible downward trajectory? You had mentioned 10 years as kind of the average for diagnosis and treatment. How do we figure what his prognosis might be for long-term recovery, or is it even possible?
Yeah, of course it is. Definitely, the earlier it is identified, and hopefully the sooner treatments, if it's bipolar disorder or even depression in general, the early identification, just like I mentioned, it can allow, and the early treatment can allow the brain to start recovering those functions that we talked about. But especially if the person is on the right treatment and sticks with it. One of the problems sometimes in mood disorders, but especially in bipolar, is that sometimes people start feeling better after a while on treatment, and they may think it's something, common sense, like I took the medications, I'm feeling better, now I can go off of them. Or it may be in the form of another manic episode or episode that make them lose that insight that they had before, where they stop taking the medications, and that can trigger more episodes. But the key thing is, yes, as soon as you get treatment and you go into remission, that allows your brain to have the chance to recover over time. So definitely there is a chance. And, when you think, one thing I didn't talk about in mood disorders is that suicidal behavior and suicidal ideations are one of the main problems with it. Up to 15% risk that someone with a mood disorder will end up, unfortunately, dying from suicide. Every step in treatment that can get the person to be healthier from a biological perspective and avoiding drugs and any of those hits that I talked about, stressors, will foster that resilience and help them, again, get to a better place. And that BDNF substance that I talked about in depression, with treatment, it goes back to a better level over time and allows the brain to start making connections, etc.
Being recently diagnosed with bipolar 2, it's kind of opened up a whole new world at age 28. And now I go back to my childhood and say, did I have those symptoms then? Did I have problems then? What are the best ways to start to identify those sources of trauma or what happened to me as a child that would have then caused this developmental thing to where I am now? On the other side of that, now that I'm an adult with a family affected by mental health issues, specifically my wife, I feel like we kind of bounce off of each other. So what is a good source that we can go to, or what is a way to prevent the escalation of mental illness within our own family as well?
Well, obviously, Brandon, you already started that process, which is getting aware and kind of even going back and studying your life, what could have happened, etc. Now, if it's bipolar disorder, typically bipolar is more genetic than depression, meaning you may have your trauma or any stress may have precipitated the symptoms to show up earlier than if you were going to have the symptoms maybe 10 years later or something like that. But in general, in bipolar disorder, it's a highly genetic disorder. And, as obviously you seem to be developing that awareness of the symptoms and the treatment and maintaining that and going back and analyzing and processing does not hurt. You may not be able to pinpoint one specific traumatic event that made you develop bipolar disorder because that's not how it works. But of course, unfortunately, families who have mental health problems, when they are not doing well, when you are depressed and you have to take care of a child, for example, that impairment that you can have can affect the way you take care of that child. Now, imagine if that child is also perceiving my depressed dad or mom as someone who's not paying attention to me, then they will be feeling as if, okay, I'm having a problem with something that is important for my development and maturation. But I think keep going and, getting involved in the treatment and psychotherapy to understand the patterns first, the symptoms, so that you can intervene if the symptoms come back. Because with bipolar or depression, sometimes you would be on a medication or two or more, and yet you may still, because of a stressor or something, an event, you may have still an episode. Now, hopefully with treatment, you may not have a depressive episode as bad as without treatment, but you will be able to tell sooner. And again, when I talked a little bit about sleep and diet and routines, those are key important things in mood disorders to be aware of, even if there's any seasonality. So for example, some patients may feel worse in winter or spring, et cetera, and they may have changes simply because the environment, like I mentioned, is affecting the brain through multiple different ways. And as such, you being aware of it, you can plan for next year. If every winter I'm gonna feel this way, you wanna talk to your mental health provider to avoid that from happening. In PTSD, similarly, from post-traumatic stress disorder, which is one of the main disorders, if not the only disorder, that is caused by an environmental attack on the brain, meaning a stressful traumatic event that happened whether in one episode that was severe enough or in a chronic episode, meaning abuse and violence and et cetera over a period of time, then the brain will use up its reserves, if you want. And then even though you had PTSD, you will start developing also depression, depressive disorders or depressive episodes. As far from if there's a couple and you both are aware of that, again, developing more and more of the patterns or awareness of the patterns, even if you need therapy for the couple or individually or both, to start, like you said, instead of feeding off of one another, being able to acknowledge that some of the behaviors could be related to symptoms, but again, we may not know if this is an episode in its beginning that is not noticeable yet. But again, the other part of it is that not everything you do or say can be always related to depression or bipolar. Again, the way I always talk to my patients is that you are a normal, as much as I don't like that term. Yes, you have problems, and they happen to be, unfortunately, in the brain and affect how you feel and how you act. But you are still a normal person, and you need to try as much as possible to always work towards through treatment, through support, to get to the best place your brain is allowing you to get, and help the ones around you. But definitely seeking support and mental health professional help to help you both understand those patterns would be essential.
I live with bipolar 1, and I have an adverse childhood experience score of 7. I'm doing a lot of EMDR, and I wondered if you knew if doing that work to process the trauma can help restore the neuroplasticity of the brain.
I don't know specifically about the research specific to EMDR, but I think the process of brain getting better over time, and we're talking not necessarily taking an antidepressant, let's say, or doing EMDR for 2 weeks or 4 weeks. Mm-hmm. Brains and the nervous system is a system that is slow to change, and the outcome will show up sometimes delayed. When we start a medication like an antidepressant, it takes about 4 to 6 weeks from the time you start in order to see some of the benefit, and then you may need to raise the dose. Similarly in other modalities, but especially when it comes to non-medication type of treatments, whether it's psychotherapy, etc. When you think about cognitive behavioral therapy, for example, there are brain imaging, meaning MRIs and scans, that could show that if you do cognitive behavior therapy over a period of time for certain problems like OCD, yes, the wiring of the brain may change, or there are different areas in the brain that are lit up suddenly because they're more active. When you think again about transcranial magnetic stimulation, TMS, one of the methodologies is that, yes, it can improve by repetition. You're asking the cells to keep producing substances to create that healthy environment for the brain in order for it to start processing. Imagine if you had a depressive episode, you probably are unlikely to be able to do EMDR well, mm-hmm. or any kind of therapy for what it's worth. That tells you about the brain as it gets better and better and better, it starts helping you address other things. And I believe I can't tell you, quote, specifically for EMDR, but I do believe by following the same logic that I shared earlier, meaning a healthy brain can start improving and make you able to cope with any stressors better than if you are able to process things that happened in the past. Having a healthier brain will be very essential in succeeding in doing that work.
So when I first started this journey of mental health, I got stuck on the idea of a diagnosis and saying, hey, what is wrong with me? And up until recently, I was stuck on that diagnosis, and I felt like it would help me to be diagnosed finally. However, now that I have been diagnosed, I was given the diagnoses of bipolar 2, PTSD, and borderline personality disorder. And now I feel like, hey, this is a lot on top of me. This is more than what I thought was wrong with me. I'm not normal, and I hate the word normal because for me this is normal. It just seems that now that one has stacked on top of the other, and I know that they're all kind of comorbid and living with each other, but in my brain and in my mind, it feels like more than what I thought I had, or more than what I bargained for.
And I see a comment also talking about high functioning doesn't mean that challenges or suffering are not present or lesser, which is hard and confusing to experience. I didn't want to miss that piece, because that also speaks about what you're talking about. You came in saying, hey, I'm feeling this, that, and the other, and suddenly you leave an office with like not one, but 3 diagnoses. And that goes to the idea of how do we diagnose in mental health? We don't have a blood test that tells you this is bipolar disorder. As much as I would love to see something that tells me, hey, your neurotrophin, the one we talked about today, is up or down, and that makes you have bipolar, depression, schizophrenia, whatever that is. We don't have that technology yet. The diagnosis is usually based on criteria that the patient meets, meaning if you have these bunch of symptoms together for this period of time, that is what we think it's a disorder. And even the word disorder implies that, because there's a difference a little bit between when you think about schizophrenia or schizophrenic disorders, if you want. These are a group of symptoms that, for the sake of us being able to communicate and not confuse the patient and the providers, and if you go to a new doctor, they need to know what was diagnosed before. So that terminology, and I like the way you framed that as well, that this is more than I bargained for. And I can tell you, you have one brain. It's not multiple brains. It is one brain, but the brain is pretty complex and expresses symptoms differently, where bipolar disorder is different than post-traumatic disorders. But when you have the symptoms from both, we have to acknowledge the presence specifically in order to treat them better. Because if we tell you, okay, you have bipolar type 2 and miss the other ones, your treatment modalities, you may still actually treat the bipolar and stabilize it, but the other ones will make you feel even worse, because now you're sitting and, okay, well, I did what I had to do. I got treatment for bipolar. Why am I still having nightmares and flashbacks? Why am I still experiencing relationship problems? So in a sense, as much of a stigma that sometimes come with the label, but I think that's exactly our role in saying that, no, you are a person who has one brain and has had a lot of experiences in your life. But yes, you have these three problems, just like saying, hey, you have high cholesterol, diabetes, and high blood pressures. They're all related, and frequently they come together sometimes. But the treatment for each one of them may be a little bit different. And that's, again, the idea. Some people may have, when it comes to high functioning, another terminology that I don't necessarily like, because functioning can vary. Some people, not everybody is capable or wants even to be high functioning. What does that even mean? So I think there is your own baseline that as you get treatment, especially with a confusing disorder like bipolar, where you have the highs and the lows and in between and together, the mixed episodes, etc., it can be a confusing mental health problem that makes you not know predictably which one am I, or you may be neither one of those. You're not a depressed person. You are someone who has depressive episodes. You're not a manic person. Again, those adjectives are totally inappropriate in my mind. You have a name and you have three different kinds of problems that can affect your functioning. But again, with the right treatment and the early identification, you will be able to function at the level you choose, hopefully, to, and hopefully the brain and the body allows you to do that.
Well, I first want to join all of the folks who are here tonight to again express our appreciation to you, Dr. Melhem, for coming to speak on the occasion of Brain Awareness Week. Indeed, your time, commitment to service in the mental health field is sorely needed at this time and appreciated beyond words, really. I also, along with Jeff and the rest of DBSA, want to thank everyone here in attendance, and especially your individual endeavors to bring about positive change. No matter how big or how seemingly small, it makes a difference. It is our hope that this event will serve as a springboard for continuing such lectures and presentations on mental health. And we invite everyone here this evening to consider joining us in supporting future meetings, whether virtual or in person. Of course, we'd love to have it in person, but this has worked pretty well. Knowledge is necessity, serving to break down barriers, eliminate stigma, and brings with it the realization that through brain research and the increasingly rapid development of more highly effective treatment modalities, we may very well see brain disorders, mental illness, totally eliminated in the not too distant future. I have great hopes, and expectations that this will come about. For more information about the Dana Alliance for Brain Initiatives and Brain Awareness Week, please go to dana.org and click, while you're at it this week, if you can, click on their calendar to see how many countries and organizations, just as like ours, are participating in this wonderful event. Also, if you're wanting to join us in developing further lectures and presentations, which of course would be free and open to the public, you can call us. Our number is 719-477-1515. We're on the web. Of course, we have a site there, DBSA Colorado Springs.org, and we're on Facebook. I don't know what more to say other than I've been privileged to be part of this organization, just as those who are out there in the field serving. And it touches me deeply to know that we're all together working for a future that is promising in light and in spite of what's going on around us. I want to thank you all for coming, Jeff and I. And I also want to just point out that a young woman who's part of DBSA just recently has been serving to extend information about DBSA in the community and beyond. Her name is Anna Boucher, and she did a great job of disseminating information on this organization presentation tonight. So thank you for coming this evening, and may each of you have a wonderful rest of the week. Again, thank you, Dr. Melhem. Thank you, Jeff, for stepping in, and we work together on this, and hopefully in the future. By the way, some of you may not know, and I hate to make this any longer, but in years past, we actually had what we called First Thursdays, where we had presentations. We sponsored and hosted presentations on mental health and related topics that were open to the public. It was when we had a larger space, we had a wonderful lending library, and many people would show up and gain a lot from that. It's our hope that one day we will be able to work towards having the same, if not better, in the future. And of course, collaboration with other like-minded organizations is more than welcome to join in. Thank you again, and good night.